So what will be the symptoms? Painless limp. Remember, it is painless, okay, not painful, and it is persistent because there is no going back into the acetabulum. And if it is persistent, then it is an incongruent joint. And if the joint is incongruent, then what will happen? There will be erosion of the cartilage. Ultimately, it will develop a osteoarthritis, secondary osteoarthritis, because of developmental dysplasia. If there is secondary osteoarthritis, now the pain can develop. So pain comes later at when the secondary osteoarthritis develops. And in case of bilateral DDH, remember there is a waddling gait or a duck-like gait, also known as sailor's gait. Because of this, the spine has to compensate the limb length discrepancy. So there will be compensatory lordosis and scoliosis. Scoliosis and lordosis. So there is exaggerated lordosis at the spine, and scoliosis can also develop at the spine because of imbalance in the length. And because of this, the joint down the line is knee joint. A genu valgum, a compensatory genu valgum can also develop, right? Suppose this is the hip, right? If this is the hip and if there is migration of this femur proximally, then what will happen? If this femur migrates proximally, the head is moving laterally also. So if it is moving laterally, then what will happen? The distal femoral condyle will have to move medially to maintain the axis. And if this femoral condyles move medially, to compensate this, the tibia will move laterally. So it will be a compensatory genu valgum, right? So this portion will go to this side, this portion compensatory will go to this side, distal femur, and tibia will go to this side. So ultimately it will be like this. So that's why there is a compensatory genu valgum in developmental dysplasia of hip, right? Now what are the signs? On inspections, we see a shortened limb. Obviously, because the hip is migrating proximally, so there will be a shortening, and that will be a true shortening. True shortening because the bony length has got shortened. And because the limb is migrating proximally, but the skin is normal, so what will happen? There will be folding of the skin, folding of the excessive skin. So we see excessive thigh fold, that too medially. So asymmetric thigh folds. Limbs in adduction, internal rotation and flexion. So that is a typical attitude for developmental dysplasia of hip. Flexion, adduction and internal rotation. Right? Palpation. Femoral pulses are feeble. Why? Femoral artery is there, but why the pulse is feeble? Because see, we feel the femoral pulse against the femoral head. That is the bony floor against which feel the femoral pulse. But now the floor has moved proximally. So the head is not there. So against what will we feel? Against nothing. So the femoral pulse will actually feel feeble because there is nothing underneath to compress upon it, to give a counter. So that's why it is known as feeble femoral pulse. But actually it is not a weak femoral artery. Artery is same, there is nothing wrong with the artery. It is just that the floor has disappeared. The floor has migrated proximally, and this is known as vascular sign of Narath. Vascular sign of Narath, that is a femoral pulse which becomes feeble. On the movement, so we have read inspection, palpation, now movements. So in movements you have to remember two tests, Ortolani and Barlow, right? Now Ortolani, take the O of Ortolani. Open and one. So the joint is open and there is one movement. Also open here means that you have to open the legs. So Ortolani is open and one. Open means the joint is open, that means it is already subluxated and you have to open the legs. So if you open the legs, that will be an abduction movement, right? An abduction movement if you open the legs. So if you open the legs and the joint is already open, then what you will be doing? The joint is already subluxated and you are opening the legs. Then what will happen? You will be reducing the joint. By the movement, you are reducing the joint because the joint is already open. So it is a one movement test. You just do an abduction, you do an opening movement and joint is already open. So you reduce a already subluxed joint. Joint is already subluxed and you are reducing it. Now the other test is Barlow. So Barlow is B by, that means two movements, two stage. So in Barlow, the joint is not open. Okay, so it is in the normal position. And what you do is, you first dislocate the joint by doing an adduction movement and then you relocate the joint by doing a abduction movement. So it is basically a by two stage. Ortolani is joint is already open and you open the legs to reduce it, and it is a one movement test, one stage test. Now the next test is telescopy test. So telescopy is basically pushing and pulling the femur. You try to telescope the femur against the acetabulum. So you basically do a push and pull movement and you feel the excursion of this greater trochanter, because that is the most lateral portion that you can feel with your palm. So feel the excursion of greater trochanter. Suppose if there is no subluxation movement, that one will happen. Even if you try to push and pull a lot, the head is in the acetabulum, there will be no movement of the greater trochanter. But if it is subluxating, then you will feel a greater trochanter sliding underneath your palm. So that is a telescopy and it is positive in developmental dysplasia of hip. Measurement. So we have read inspection, palpation, movement and measurements. What in measurements? We see a short limb, right? We read in inspection that the limb appears shorter. In measurement, we are actually measuring the shortening of the limb length. So it is about a Galeazzi or Ellis sign. They're basically both. Whether we are performing the test in lying down position with knee hair, hip hair and foot hair, whether we are doing in this position or we are doing in hip, knee and foot, in knee 90-degree position. So basically means the both the same, whether it is Galeazzi or Ellis sign. Okay, so basically tells about the short limb. If this hip is subluxated, that means this femur length will come to the posterior side. This femur will be shorter. So if this femur will be shorter, so the knee joint of that side will appear a little lower. So if this hip is subluxated, this is a DDH hip. Because of the subluxation of the femur is going posteriorly. So the limb length will reduce and the thigh will appear shorter, right? Now we have something called Clisic's test or a shoemaker line test. In adult it is shoemaker line. In children we do it with 3 fingers, so we call it a Clisic. They basically have the same method. So in Clisic test, we take umbilicus, anterior suprailiac spine and greater trochanter, and we try to see them whether they are in single line or not. So if the line joining this greater trochanter ASIS crosses the umbilicus, then it is Clisic negative, or shoemaker line is crossing the umbilicus. But if it is crossing below the umbilicus, that means there is proximal migration of this end, greater trochanter. So this line will go towards this side, it will appear like this. So Clisic test or shoemaker line, they are basically both the same thing. And then we have a positive von Rosen sign. So positive von Rosen sign is present in developmental dysplasia of hip. Then we have radiographic assessment, X-rays, a basic investigation. Now there are some lines that you have to understand on X-rays in pediatric hip. There is something called Hilgen-Renner line, which basically joins the both triangular cartilage, triradiate cartilage. So a line joining both the triradiate cartilage is called a Hilger-Renal line. Then there is a Perkin line. Perkin line is a vertical perpendicular line dropped from the lateral edge of acetabulum. Okay, and then we have Shenton line or Shenton's arch that we have read in adult neck fever, also in trauma, also a breakage of Shenton arch. So this is the Shenton line, the lower border of the superior pubic rami and the medial edge of proximal femur. Okay, Shenton line. So normally the femoral head lies in the lower inner quadrant. Okay, if we divide with this Perkin line and Hilger-Renal line into 4 quadrants, 1, 2, 3, 4. So normally what happens, the head lies in the lower 4 quadrants. You can see it here. This is the Perkin line, this is the Hilger-Renal line. So here is the head. But if the acetabulum is shallow, then what will happen? There will be proximal migration. So head will not be in the lower inner quadrant. Normally head is in the lower inner quadrant. But if it is subluxatable, it will go proximal. So it will be somewhere here, upper outer quadrant. Okay. And the Shenton line will be broken. This line will break because this will move proximally. So that you have to see in the X-ray film. What else? Extracellular lines and indices. So if we make a tangent from the triradiate cartilage to the lateral edge of the acetabulum, and if we measure the angle from the Hilger-Renal line to Hilger-Renal line and the line from the center edge, then this is known as acetabular index. So if this acetabulum is not shallow, it will have a overhanging edge, but if it is shallow, then this acetabulum will be somewhat like this. So this angle will increase. So acetabular index will be increased, like in this case. Okay. So acetabular index will increase. Center edge angle. Okay, now we are measuring the angle between the Perkin line and the center of femoral head, and a line crossing from the center to the edge of acetabulum. This is center of femoral head, this is edge of acetabulum. So this is center edge angle. This line can also be drawn in adults, like we can drop a perpendicular here from the center and we can measure this angle. So these two angles will be the same, like in this case. So if we drop a line from the center of the femoral head and we measure the angle like this, or we drop a line from the lateral edge, that is a Perkins line, or we measure this angle, these angles will be congruent, they will be same. So center edge angle will be decreased. Why? Because this acetabulum is shallow, this will move somewhat like this, and if this goes up like this, then this angle will become narrower. Suppose this is the angle right now, and if this is moving proximally, then if I draw a line here, because the femoral head is still here, then what will happen? Because of the movement of this point proximally, this will become narrower. Okay. So center edge angle of fever will be decreased. And remember, there is associated delayed and retarded development of head of femur, because for development of head of femur, the containment in the acetabulum is necessary. They are basically both complementary. If the head of femur is contained, the acetabulum will develop. If the acetabulum is containing the head of femur will also develop accordingly. So it will also be abnormal. So there will be smaller epiphysis for the head of the femur. Now there are two angles in ultrasonography, alpha angle and beta angle. You don't have to remember how they are measured, just remember what happens when beta increase or alpha decrease or beta decrease. So just remember, beta is bad, beta is bekar. When bad thing increases, they lead to severe issues. So in ultrasonography, remember, they are not on X-ray, they are on ultrasonography. On ultrasonography, if beta increases, it will be a severe type of DDH. So if beta decreases, it will be a better type of DDH, or with the corollary, if beta increases, it is bad. So if alpha increases, it will be good, right? Remember, beta is bad, okay? And MRI is the investigation of choice. USG is the investigation for screening, okay? So screening, all neonates should be examined at the birth for this. And ultrasonography is done at 6 weeks usually. Okay, so clinically you examine at the birth, and with ultrasonography you do at 6 weeks. Now what is the treatment? We read about the pathology, the epidemiology, everything. Now we have to go for the treatment. So if the child is presenting early, for example 1 to 6 months of age, then close reduction with maneuvers. Then you contain the reduction with the help of Pavlik harness, hip spica, or a bachelor's cast. Remember these words. Then there are some splints which are outdated and they have been shown to increase the problem in the DDH, which are von Rosen splint, Freca pillow, and Craig splint. They are not used now, they are obsolete. Right? So treatment of choice is Pavlik harness in 1 to 6 months. Remember this age group also, because it will be asked directly in your exam. They can ask what is the treatment of choice in 3 years, 6 years, 10 years, 12 years, or 1 to 6 months. So you have to remember the treatment of DDH according to the age group. So in 1 to 6 months, close reduction, then use a Pavlik harness or a hip spica bachelor's cast. And also remember excessive wide abduction, because you are abducting to reduce the limb. So excessive wide abduction and internal rotation of the femur to contain the femoral head can lead to AVN of the femoral head. That is a complication. Avascular necrosis of the femoral head. Okay. In 6 to 18 months, we have read about 1 to 6 months. In 6 to 18 months, close reduction is usually not possible because of the thickened labrum and contracted capsule, hourglass contracture, excessive fat or fibrofatty pulvinar, hypertrophied ligamentum teres. Close reduction is usually not possible. So we have to go for open reduction. We go for a surgery, we cut the capsule, we cut all the hypertrophied tissue, we reduce the hip, and then we apply the Pavlik harness or preferably a cast, a hip spica, open reduction plus hip spica. That will contain the femoral head. In 18 to 16 months, right? So basically 1.5 to 3 years, 18 to 16 months. Open reduction with cast is not enough. You have to go for open reduction plus femoral osteotomy also, so that you can rotate the femur. Femoral osteotomy and pelvic osteotomy to contain, to modify the shallow acetabulum. So you do a pelvic osteotomy here, you increase the roof of acetabulum so that you can contain the femoral head. So 18 to 16 month, open reduction plus femoral osteotomy plus pelvic osteotomy. See, it is very young age, 1.5 to 3 years, and you are going for such measures. In 3 to 6 years, you have to go for acetabulum reconstruction procedures. You have to completely reconstruct or recreate the acetabulum. So just doing a simple pelvic osteotomy is not enough. You have to do a proper pelvic osteotomy and you have to rotate the pelvis so that you can reconstruct the acetabulum. Suppose you do a pelvic osteotomy here and here, then you rotate this pelvis in this direction. So this shallow roof will become somewhat like this. So that will be a acetabulum reconstruction. You have reconstructed the acetabulum, and one of those is Salter osteotomy. So Salter osteotomy is used for DDH and it is used in 3 to 6 years of age. That you have to remember from this slide, okay? In 6 to 10 years. In 6 to 10 years, you again for unilateral cases go for acetabulum reconstruction. Okay, in bilateral cases, you just avoid any treatment in this age group. You don't go for any treatment. Why? Because later on you go for total hip replacement. There is no benefit of doing a procedure in bilateral cases in this years of age. So you wait for some time and you do a total hip replacement. Right, so that is a treatment in more than 11 years. So let's see again, 1 to 6 months close reduction plus Pavlik harness or hip spica. 6 to 18 months open reduction, not close, plus hip spica. More than 1.5 years, 18 to 36, open reduction plus femoral osteotomy and pelvic. More age, 3 to 6, acetabulum reconstruction, among which is Salter. 6 to 10, unilateral, again acetabulum reconstruction, bilateral treatment, nothing given. And more than 11 years of age, you go for hip replacement. Okay. So now let's take a break and then we'll discuss the next topic.